as well, I have to say, and thank you very much to the Migraine Association for facilitating it. I'll see if, so.
You should, Mary.
We're doing good.
Yeah, super. Thank you, Mary.
Yeah, you're there,
Thank
Mary.
you.
Yeah,
that's wonderful. There. Thank you so much.
So it's a great honour for me, and I've worked for a long time in general practice, and I decided to take a little step back from full-time general practice, and I've concentrated on headaches in recent times. I have a few other interests. I'm a member of the Cochrane Collaboration, and I'm also involved in the European Reference Network, and it's for rare diseases of a neurological nature. And they've been using virtual consultations and looking at it for the last 10 years. And in fact, it has given me great experience in running it. I'm really not from any high-rising university, and this is Dunlavin at its best. And I've no financial interest in any of the matters or the drugs to date. I have written this document, and it's freely available on the ICGP website on migraine, and I've written it in conjunction with Dr. Martin Rutledge, our national expert, and Nurse Esther Tompkins, who's a wonderful fountain of information and experience. And my figures differ a little bit from the Migraine Association ones. Dr. Martin, in fact, he says there's 750 people in Ireland with migraine, where you were saying about 500,000. Anyway, this was at the launch of our document. And, you know, 95% of all headaches that people have are migraine, and 42% of all women, so that means 1 in 2 women will have a migraine headache during their lifetime. Ironically, it was the men in my family who had migraine, and by gum, they did suffer with it. And then we all knew about it. And I mean, when you think of 1 in 10 people will have a migraine on more than, of those who have migraine, 1 in 10 will have a headache on more than 10 days per month. Now, it's the leading cause of disability in this group of women. And of course, Marie has already said all of this. And for years lived with disability, it's rivaling back pain, according to the WHO. And I truly believe that. I have a couple of cases, and mostly I have a couple now, but a couple later as well. And these are the problems. A school teacher with migraine, and she goes to bed at 8 o'clock in the evening when her 5- and 7-year-old is going. She's tried not to miss any time from school, but did her principal know she had migraine? We've luckily been able to turn around her life effectively. And she's become a productive member of staff, and now been able to push the boat out to get some improvements for her school. But what we managed to do for her was to get her in as a remedial teacher, so that if the migraine was coming, she could take her medication, retreat to a less noisy room, as you can imagine what infants and senior infants are like, and her migraine would be helped. The next lady is the journalist, and she gets the weekend migraines. Does her employer know? No, she certainly didn't tell him. And she knows all about migraine because her father had it. We're hoping to do something pretty good for her as well. But really, this is where discrimination comes in. And then what about the nurse? Well, she had a history of being on night duty in her early 30s, and she developed migraine on 10 or 12 days per month. So at 42, she's asked to go on night duty again. So what can we do for her, or how can we go forward? So we've had this. It's more than a headache. It's different from every other headache. It's very common. And there again, I'm quoting the Eurolight summary, and this is something Leo will elaborate on. That 37 we'll say 37% had migraine, of which a third had migraine on 5 days or more per month. So they would have been suitable for preventative treatment. And Leo will talk about the awareness of migraine and the misdiagnosis. And I'll talk about that in a second myself. But in the general population, only 13% of people with migraine saw their GP, and only 7% got adequate treatment. And I'm pretty sure that the figures in Ireland are pretty much the same as Spain, and certainly that's been my experience. I just have this photograph of an aura. There's 20% of people have migraine with aura, and we'll talk about it later, but I just think it's a very good picture. Deirdre at the Migraine Association was involved in me getting such a good picture, and it's courtesy of Shuttercock, just to give you an idea what it's like for them, for those of us who don't have migraine. And this is about the problem, about the diagnosis. The top line is migraine, tension-type headaches, medication overuse headache, and I want to discuss that later. New daily persistent headache, I have a little slide towards the end about that. And then we have the non-migraine headaches. And I know this is very busy, but I want to say that, 30 years ago and 40 years ago, people were diagnosed as having tension-type headaches and sinus. But in fact, Dr. Martin Rutledge and myself are now doing a document on non-migraine headaches. And both of us feel that people who were previously diagnosed as tension-type headache and sinus-type headaches are actually possibly low-grade migraine. So these are the things you must have for a migraine headache. And there again, shall I say, the Migraine Association sent this exact poster, well, maybe slight differences, to all the GPs in the country. When the classification came out in 1990, I had it on my general practice wall for years, and people often came in and said, oh gosh, I've tension headaches, but then we'd go through the criteria here for migraine and they'd find, yes, I have migraine. And this is available still from the Migraine Association, and it's great to have it. Now we just try and proceed to the next one. So the symptoms of, sorry, this is now Deirdre has, or Marie has already touched on this. It's more than just a headache. The headache is here and it can last for 4 to 72 hours. But before that, you have an aura. And the aura I just showed you there with the shimmering lights, only 20% of people with migraine get it. But even before that, you have the food cravings, the neck stiffness, the fatigue. In fact, it's not uncommon for me to have maybe a lady in and her husband is there and she's telling me all about the headache, and he interrupts her and he says, but dearest, I know when the headaches are coming on. You just get so tired and so cross, and I know when they're coming. So this is the prodrome. And ironically, quite often I do see the partners and husbands of people coming in. And then he'll go on to describe the postdrome, which lasts a few days, where you have the fatigue and the yawning, and maybe it's time for breakfast in bed. So it's not just a headache that lasts whatever length of time, maybe one day at work. It's all the things. And really, when you have the headache, you're tearing your head out. You have all these symptoms. Neck pain is one I just want to draw people's attention to. Stuffy nose, sinus symptoms. They're all part of migraine. It's a huge lot of symptoms. So the international classification came out in the early 1990s, and you must have at least 5 episodes of headache lasting 4 to 72 hours, pulsating or throbbing. But there, as I said earlier, you could have a mild migraine. Episodic migraine, if you have it for maybe 1 or 2 days a month. Chronic migraine, if you have it for 15 days a month. And is it more common in the women than the men? Well, as you can see here, at an early age, before 10 years of age, I'm sorry, my pointer is not working well. The boys at children have it a little bit more common, but as they get older, the women have it more common. And then the women have it, it comes on very commonly when they're, in the early teens and up to 19 or 20. It doesn't come on quite as much in the 20s. They still have it, but then again, you see an increasing incidence as people head towards the menopause, and it can last right into the 80s, unfortunately. The triggers, now these are so important. Stress, 80%. Hormones, 65%. Not eating, 60%. Weather. I don't think I need to go into them all, but the stress and the hormones. And I just want to draw your attention to the cheese, chocolate, and red wine. These were considered to be triggers. This is no longer the case. These are cravings that happen in the prodrome before you get the headache. You feel like these things, people eat them, but they don't cause migraine. So what makes you more likely to get it? Well, it's not just one thing. It's really, maybe you have a period, and maybe it doesn't make any difference. And of course, the men don't have periods, but the bit of stress at work, the late night, And then you miss the dinner and my goodness, you have a dinger of a migraine. And of course, the family history, how strong your family history is. And Claire, no doubt, can tell us, we've seen that already with Claire. That's what I said, my thunder has been stolen, but that's we need to emphasize these things and keep emphasizing them. So I like to keep this in mind, the ideal lifestyle. So it's early to bed, early to rise, breakfast at home. And it's not all stress. Take the person who's getting up for a 4 a.m. flight for a 9 a.m. meeting in London. They get as far as the airport, they're on the flight, and they just get a dinger of a headache. I mean, we can't say that's stress. It's the underlying circumstances. And it's just not all stress. And what's a good diet? Well, you just have to look at the food pyramid and just think about it. And I can't recommend one thing over another. So we've dealt with this about the cheese, chocolate, and red wine. Very important thing is to have a diary. And the Migraine Association have led the field. In fact, they got international awards and they're well respected in the European Headache Society for all the work they've done. And this is very important. More recently, you have a migraine buddy app on the phone, and I recommend this to people. But all too often, when I ask for a diary, all I get is a blank page, which is not helpful. So the headache starts at work, and what's the best thing to do? So it very much depends. But for those with the migraine, they should have their medication into hand. For the employer, maybe if you just had a quiet room and give the person an extended break, it can just make the difference. I have one lady who can't take her acute medication because it makes her feel drowsy, and she doesn't take it at work, and then she has a headache for 3 or 4 days. So I'm just trying to coax her to go and tell her employer to have the courage to say it to him and try and break the cycle. And of course, if you're a mother with small children, phone a friend, have a friend you can rely upon. There's a good few medications you can have, and I suppose for this group it's not so important, but there is lots of medication, and there is this is a framework which Dr. Rutledge here and myself and Esther have adopted recently, and we have it. He gives it to his patients at all the clinics, as I do myself. There's a couple of different ways of taking the medication, and you can imagine if you're going to take the suppository, you might want the cream, or you might need the room for the injection. You get if you do give a little injection, it works quite quickly, or the nasal spray, but the nasal spray works well, and so do the tablets. So avoid morphine and opiate-based medications if at all possible. And we would advise people to consider preventatives. Even if your GP is not on for it, you could perhaps go and talk to them about it and bring the migraine document with you. So, so the next thing is the medication. Yes, this is how many sumatriptan can you take? Sorry, just to get this sorted. I think we just need to admit these people. I might get somebody. So how many sumatriptan? These are the ones you take for the acute headache. Can you take without over-medicating? You can really only take them for 4 to 6 days a month. And if you take them for more than 10 days a month, or if you even take paracetamol more than 15 days per month, you can be considered to have medication overuse, which in turn can lead to medication overuse headache, which is what I alluded to on the very complex characteristic table I produced earlier. And so the definition is, we've gone through the definition that it's 15 days for some medication and 10 days for the stronger medication. And this is how you're worried about a headache coming, so you take some painkillers, the pain goes, and then you're worried about another headache coming, and it gets into a vicious circle. And before you know it, the migraine headache that you had before is even worse than what you had. So personally, I feel if you have migraine on 5 days per month, it's quite disruptive, and it's really time to be thinking about prevention. If you have migraine on 8 to 10 days per month, and considering that an attack can last 3 or 4 days, you only have to have 2 attacks per month to be definitely considering preventative treatment. If you have a poor response to acute treatment, it's also worthwhile considering about. So the current preventative drugs we have were discovered by accident. A clinical trial in Norway was using candesartan for blood pressure or hypertension. And those people taking it discovered that their migraine was better. And candesartan has become one of the better drugs and the newer drugs that we've been using. We have new drugs called the CGRPs, and the Migraine Association has lots of information on them, but unfortunately, they're not available in Ireland yet. They're available in special circumstances in some places, through a program that Novartis have been involved with. But expense will be an issue, and given the current COVID crisis, I'm sure it may be even a little longer. They still have their drawbacks, and unless you really look after yourself as a migraine person, they won't work. So what preventative medication would you go for? Well, it depends upon your other issues. It depends upon your health, drug interactions, and unfortunately, I find migraineurs are very sensitive to medications. We'd expect you to improve between 30 and 50%. And while that may not seem too much, to migraineurs who are really struggling, they're pretty pleased with it and they're happy. But you need to give the drugs an adequate time to work. All too often, I find people don't take them, they don't give them long enough to work. This diagram here has days on the bottom, and you can see that this is where they start their treatment, but by 30 days, a lot of people have given up their preventative drugs. Unless you take them for 3 months, you can't really know whether they're working or not. You need to give it an adequate trial of 3 months at the maximum tolerated dose. So you might you go up every 4 weeks, usually if you're increasing your dosage, and you know, the maximum dose, your doctor will have told you what the maximum dose. So you have to take the maximum dose for 3 months before you can say, no, this is not working. Unfortunately, it's quite common, as I said, that migraineurs develop side effects, and you may not develop the side effects at a lower dose, but as you increase the dosage, you might. And sometimes if the side effects are too severe, you just have to stop. What I find in clinical practice, that sometimes you have to put people on a combination of drugs. And really and truly, sometimes I say to people, oh, you're on 3 different things. And they'd say, no, I'm not on much, doctor, because I'm taking no acute medication. I'm really happy to take these 3 drugs at a very low dose, and I'm doing really well. I want a few words about hormones, because 60% is related to hormones. I personally think that's a bit high. There's a medical classification about migraine associated with a woman's hormones. You can have pure menstrual migraine, but that's present in 7 to 15%. And I'll talk about that in a second. You've menstrually related migraine, where attacks occur during the period and at other times. And then you have migraine, which doesn't happen, related to menstruation. Now, so there's 3 different options as a woman you can have. But in order to make a diagnosis, you have to look at the diary for 3 months and see where they are. The pure menstrual migraine is the one that is really precipitated, and they're unfortunately the people who get really bad migraines, and they don't often respond to the usual treatment. That is the triptans and the Zomigs and the injections and the nasal spray that I showed you. But what does seem to work for them is to keep the hormone steady. And you can do that by taking Cerazette or desogestrel. It's a progestogen-only hormone, which is it's a progestogen-only, I emphasize again, that is safe in migraine. Some people say that the Mirena coil works, but there is international disagreement over that. And I wouldn't be happy to recommend it either, from my clinical experience. Sorry, thank you. This is prevention. Now, the choice of preventative medicine, it depends, we've discussed that one. Now, the first line preventative treatments in Ireland are topiramate. And this can be used in the presence of medication overuse headache. we prefer if it wasn't used. So if you start at 25 milligrams, the maximum dose that's recommended for the treatment of migraine is 400 milligrams. So you would have to increase every 4 weeks by 25 milligrams until you get to the maximum dose of 400 milligrams to know whether it was working. Amitriptyline is a very good drug. And it's taken at nighttime. A lot of migraineurs have trouble with sleep. Lots of them, as Marie said, have comorbidities, like they have fibromyalgia. And amitriptyline is really suitable for those kind of people because it helps the fibromyalgia, the sleep, and the migraine. It doesn't work overnight, and you definitely need 1 month and possibly 3 months before you can say, no, it is or it isn't working. Propranolol is tried and tested, and it's a wonderful drug as well, depending upon the circumstances. And candesartan is the newer one that I mentioned, that was discovered in Norway, and it's doing really well. For people in their 40s who might have borderline blood pressure and migraine, this is a really useful drug. Or even if you have migraine and a family history of blood pressure, I think candesartan is an ideal choice. It's got less side effects than both the topiramate, the amitriptyline, or the propranolol. So this is the migraine. We're repeating ourselves here a minute with the menstrually related migraine. We'll just keep going. Migraine in pregnancy, I have just a few words to say about that. The good news is less than 8% of women are worse during pregnancy. But as 41% of Irish pregnancies are unplanned, and that is information from 2015, one needs to be careful about topiramate in women of childbearing age, because if you have an unplanned pregnancy and you're on topiramate or epilim, it's not satisfactory and it's not appropriate. So the challenges that are presenting to us, despite all this medication and all this information, the challenges presenting with a 42-year-old with a new daily persistent type headache is really challenging. I'm just mentioning new daily persistent type to let those of you who are not migraine sufferers know that some people have a headache absolutely every single day. And they can tell you on what day it started. And it can be so difficult, so very difficult to do anything. They have to go through a myriad of treatments. And there is some hope with the new CGRPs that we will be able to help those people with the migraine of the new daily persistent type. What can she say to her boss about when she'll be better? Well, she's just going to have to say, as I said, she has to go from 25 milligrams to 400 milligrams. She'd have to be on the 400 milligrams for 3 months. And it is going to be challenging, and it's real. And it's not stress, it is migraine. I just want to finish by saying a couple of milestones and to give you hope for migraines treatment. As you saw, I've done more than a few days in general practice, and when I started, the triptans hadn't even come on And as I said, it was the men in our family, and the triptans revolutionized their life for them, thankfully. And hopefully the CGRPs in this world will help those who don't respond to the triptans. International classification is very important as well. So in summary, the diagnosis needs to be exact. It's time consuming to make a diagnosis. You need to go through the history with people, and sometimes it takes a couple of consultations. I had one poor lady with pure menstrual migraine, and it took us 1 full year to realize she had it. Now, she wasn't good on the diary, but after a while she realized she had to be precise about the diary. The treatment is difficult, lots of side effects. We have to keep trying, and we can't give up. It's all expensive, and I always like to pay homage to Ray Forbes for doing this, to keep it in perspective. While it's expensive, and maybe while in an employer situation you're thinking expense when it comes to your employee, sometimes it's the little things in life that help. The regular exercise, lots of drinking. And I know there's a query at the moment about face masks and migraine, and it's getting worse. And they feel that because the face mask is on, people are not hydrating enough, they're not getting out into the fresh air, and they're stiffening up. So sometimes the simple things, we lose sight of them, and we just have to keep them in mind for migraine. And we'll let Leo and Claire talk about the employers. We've covered enough of that already. Thank you so much for your attention and for the the privilege of addressing you today. I hope it's been informative, and I hope you'll get some benefit from it.